Good afternoon, everyone. So my topic is about disc edema. So a couple of things before we actually chip in. Basically, there is whether actually we have a disc edema or not. That is one thing, and normally a disc edema can be unilateral or bilateral. So this is how we are going to proceed with the discussion. So basically, before going into a true disc edema, we are going to talk about pseudo disc edema first. Basically, there is an elevation of the optic nerve head or peripapillary tissues without any exoplasmic stasis. The possible causes could be optic disc drusen, anomalous vessels, vitropapillary traction, morning glory syndrome, Buckminster's papillae, medullated nerve fibers. The features here we need to look into is how the disc is. It is usually yellowish. The vessels are more abnormal. There could be bifurcations or trifurcations. There is no associated hemorrhages or exudates or cotton wool spots. And if you do an FA, there won't be any leaks. Just more of a discussion on optic disc drusen that is commonly seen. So it is basically a proteinaceous material within the retinal ganglion cells. Most commonly, if you need to diagnose this, these patients do not have vision drop or they don't have an RAPD. If you are confused whether the patient has an optic disc drusen, kindly do an autofluorescence and you could actually see a hyperfluorescent bodies could be picked up. OCTs are a newer way in where you can actually see these low dark signals followed by along with hyperreflective bands above the lamina cribrosa, and still not possible. So you can do a B scan. You can actually pick up these highly echogenic with postacoustic shadowing. So coming to true optic disc edema, there is swelling of the retinal ganglion cells with exoplasmic stasis, and you actually need to see with your binocularly with there is an elevation of the disc on indirect or slit lamp. There is associated edema of peripapillary nerve fibers, peripapillary hemorrhages are there, congestion and hyperemia of the disc, along with peripapillary folds or subretinal fluid, unlike what we saw in pseudo disc edema. So if a disc edema can be unilateral or bilateral, just a discussion on unilateral. So if you have identified it's a true disc edema, you have to take a thorough history of the patient, in which it includes visual symptoms, whether the patient has blurring of vision, whether the scotomas are there, if it is associated with pains. You have to see for symptoms of raised intracranial pressure, where you have to ask for presence of any headaches, tinnitus, or transient vision obscurations, associated lateral nerve palsy if there is. Check for signs of meningitis, that is either there is associated fever, neck stiffness, or focal neurological signs. After the history, you need to assess the visual functions, how the vision is. You have to do a color vision just to see if it is changed or dropped. Check for an RAPD, and followed by if you can do a visual field testing in the OPD itself, followed by good ocular examination. Ocular examination should be anterior in the perfundus examination. In the posterior segment, do look for signs of vitritis or retinochoroiditis if there is, and associated vascular changes if there is, where there is vessel attenuation, sheathing of vessels, or presence of any optociliary shunts. And then you can go for the formal visual field testing, look for OCT findings, fundus photos, and autofluorescence for your confirming the diagnosis. So most commonly, we have this true disc edema, which is there. It can be unilateral or symmetric. And that is the most commonly. It is secondary to increased intracranial pressure. And when you see these sort of patients, there is an asymmetry in the disc edema, and the there is no presence of an RAPD, unlike what we see in optic neuropathy. So one of the true signs which you can look in, if there is a disc edema, look in for the vision, look in for an RAPD. If the RAPD is not there, usually you don't tend to have, the diagnosis goes more towards going into papillary edema rather than going into a neuropathy. So coming more into about benign intracranial hypertension, where we have diagnosed that the patient is possibly having a BIH. So it is usually seen in females of childbearing age with an elevated BMI. They may have the symptoms which we mentioned before. We need to ask about their medication history of tetracyclines, vitamin A, derivatives. You do an field effects are normally not there. And in these sort of patients, we need to actually confirm our diagnosis doing an MRI with contrast with MR venography. So these are some telltale signs where we can actually pick up there is a raised intracranial pressure, in which we can actually see a flattening of the posterior sclera, descension of the optic nerve sheaths we can see here, and partial or empty sella, and we can actually have stenosis of the sigmoid or the transverse sinus. So these are some signs which can pick up. When the patient has an edema and you do an MRI, and these are the signs which can actually confirm our diagnosis. So if it's a BIH, the treatment is weight loss. The patient is asked to reduce weight. We give acetazolamides, and in refractory cases, venous sinus stenting could be done.
Skip the treatment part, and I think we'll have to.
Coming to optic neuritis, as we mentioned before, these patients can have, you look for an RAPD and ask for associated pain on ocular movements. If that is there, the treatment, the diagnosis is more towards optic neuritis. And it could be idiopathic, or it could have some sort of associated infections or inflammatory problems. So the MRI with contrast could pick up optic nerve sheath enhancements. And these are some of this investigation one should do. So this is one flowchart where you can see if it's an optic disc edema. We need to rule out if it's a pseudo disc edema or not through our scans. And then once that's done, you can have abnormal neuroimaging if it is present. The possible causes could be papilledema or an optic neuritis or a meningioma. And if you have a normal neuroimaging, the possible causes would be an NAION or ocular inflammation, vein occlusions, diabetic papillitis, neuroretinitis. So NAION could be seen with an acute loss of vision with optic nerve swelling. It could have a diffuse or a segmental disc edema, which can be picked up on a HFA. And the treatment is not there. And the risk factors could be, we need to treat the risk factors, that is sleep apnea, hypertension, diabetes, smoking, stopping smoking, and hypercoagulable states. Other things which we actually need to look into disc edema.
I think this bit has been covered already. Fine. So because of paucity of time, unfortunately, we can't have too much of discussion on this also. Just one comment from you, and maybe Dr. Malika can add the concluding remark.
Ma'am, I just wanted to emphasize about bilateral disc edemas, which we commonly tend to see in our, this is hypertensive retinopathies. So if you have a younger patient who comes with bilateral disc edema, instead of doing an MRI, check for the blood pressure. And then after that, you can, if the blood pressure is normal, then you can actually go back doing the MRI and going into the treatment part. That's it. Thank you.